Okay, we're going to start then.
Okay, so it's a great honor for me to introduce our next speaker, who is Dr. Rossitza Lazova, Associate Professor of Dermatology and of Pathology and Director, Dermatopathology Fellowship Program. Dr. Lazova's research interest is mainly melanocytic lesions, and within the melanocytic lesions, the Spitzoid lesions. When first I heard her to talk about this topic that she's going to present, I was really amazed, and I liked it so much because it represents an out-of-box thinking compared to what we do day in and day out in our practice in dermatopathology. If you kind of compare the H&E approach that has been used for a very long time, mass spectrometry is really sounding and looks like a very interesting and new way of tackling this problem that we cannot solve on the level of the H&E sections. The only other thing that I would like to tell about Dr. Lazova, that she's also very active at the International Society of Dermatopathology and the American Society of Dermatopathology. She's a wonderful colleague and person, and she basically come to this program as a courtesy for us, and we greatly appreciate her giving her time and teaching us on this topic. Thank you very much.
Well, thank you, Laszlo, for this wonderful introduction, which I'm not sure I deserve, but it's my great pleasure to present today to you a new approach to studying melanocytic lesions, and perhaps a new tool that can help us in dealing with the difficult melanocytic lesions, which are not easy to be classified as either benign or malignant based on our histopathologic microscopic examination, which is the gold standard, still the gold standard over after hundreds of years. So Spitz nevus is, we all know it's one type of benign nevus, usually develops and grows fast in children and young adults near the knee, the face, cheeks. Central face is also one of the most common sites. But how can we tell which one of these lesions would metastasize to the lymph node and would kill the patient? Often under the microscope there are conflicting histopathologic criteria when we deal with difficult spitzoid lesions. When we encounter the classic lesions, as we can see on the left-hand side, the Spitz nevus, and on the right-hand side, spitzoid melanoma, then it's easy. In a Spitz nevus, we see asymmetric distribution of melanocytes. If we draw an imaginary line in the center of the lesion, one half is a mirror image of the other. So the lesion is symmetric, wedge-shaped. At the medium power magnification, we see nests of melanocytes that are positioned in the epidermis and in the dermis. In the epidermis, they are oriented vertically. There are clefts around the nests of the melanocytes and the hyperplastic epidermis. The nests mature with their descent into the dermis. The melanocytes are large and epithelioid, and they are relatively monomorphous. On the right-hand side, we have a lesion, melanoma, that resembles a Spitz nevus. However, even at low power magnification, we see the asymmetry. In the lesion, we see numerous nests of melanocytes that grow back to back and form sheets of melanocytes in the dermis. The melanocytes are large, they are pleomorphic, and there were numerous mitotic figures in the dermis, particularly at the deep portion of the lesion. When this classic criteria for benign on the left side and for malignant on the right side are present, our life is easy. However, our life is not always easy because there are spitzoid lesions. The spitzoid lesions are a spectrum. at one end of the spectrum is the benign form of Spitzoid lesion, Spitz nevus. At the other end of the spectrum is the Spitzoid melanoma. But in the middle, we have lesions that show some histopathologic criteria for a nevus and some for Spitzoid melanoma. So, of course, within this middle category, with this gray category of atypical Spitzoid neoplasms, we put some Spitz nevi with atypical features. We put lesions that for sure we cannot tell whether they are benign or malignant, and we put some atypical Spitzoid lesions for which we favor Spitzoid melanoma, but sometimes we're hesitant to call it, particularly if the patient is young, 1, 2, 3, 4, 5 years old. I mean, really young patient to be labeled with Spitzoid melanoma is very difficult. So here is one of these very atypical Spitz lesions. It was on the left cheek of a 6-year-old girl. At this magnification, we see that the lesion is clearly asymmetric. In addition, there are nests on this side and prominent inflammation. There are melanocytic nests that vary in size and shape, and they merge together to form sheets of melanocytes in the lower dermis. Here is a very large nest with irregular shape, very dense proliferation of epithelioid melanocytes with prominent nucleoli in their nuclei, mitotic figure, another one, and some within the lower portion of the lesion. So this is clearly a lesion in the gray area, which we call a typical Spitzoid neoplasm or a typical Spitz tumor. So what do we do when we encounter a lesion like that? We study it carefully for a long time. We scratch our heads. What's happening? We show it to our colleagues, and we all study it very carefully, or we send it out for consultation. But when encounter these lesions in the gray area, we often seek a second opinion in an attempt to get a correct diagnosis and for medical legal protection, particularly important in the United States. However, the second opinion is not always correct, and even experts frequently disagree in their interpretation of atypical melanocytic lesions, particularly the Spitzoid ones. It's important to choose an expert because some experts we know are very benign, some experts are malignant, and some experts are indeterminate. They often say a melanocytic lesion of undetermined biologic potential. There is a great interobserver variability and discordance in expert opinions, which has been published in the literature on numerous occasions with different workshops and different experiments made with the experts. We often try to use immunohistochemistry in our attempt to try to differentiate Spitz nevus from Spitzoid melanoma. However, there is not a single magic marker that can help us in that differentiation. Comparative genomic hybridization and FISH are some molecular studies that we use also in the differential diagnosis. In CGH, the entire genome is analyzed for copy number changes in the DNA content. Most Spitz nevi have no alterations of the DNA copy number, whereas 95% of melanomas show multiple chromosomal aberrations. In addition, about a quarter of the Spitz nevi show an isolated gain of chromosome 11p, which is the site of the HRAS gene. Now, I'd like to talk to you about the important role of the proteins. Of course, genes and genomic load genomic composition is very important, and genetic alterations play an important role in carcinogenesis. However, genes may or may not be expressed, and the gene expression does not always correlate with protein translation and does not account for post-translational modifications. Proteins, however, are the main carriers of biologic activity and have fundamental effect on cellular function or dysfunction. All the enzymes are proteins, basically many of the very important constituents and neurotransmitters and everything. Most of these are proteins. So it's extremely important to measure the gene activity at the protein level, which is much more informative. Mass spectrometry is a method which can analyze different metabolites, small molecules, lipids, DNA segments, peptides, and proteins. It determines the molecular weight of the molecules using a mass-to-charge ratio. I did my studies at Vanderbilt University. Dr. Caprioli, in 1996, invented a method by which one can study protein composition of tissue on formalin-fixed paraffin-embedded tissue sections. It was not, this method was not used before that, and since he invented this new method of studying formalin-fixed paraffin-embedded tissue sections, now we were able to study proteins in this tissue. Proteins and peptides are involved in the development and progression of diseases, especially cancer. Now, mass spectrometry has the ability to discover molecular signatures of diseases and cancer. Molecular signatures are typically comprised of 5 to 20 different proteins that together result in robust diagnostic patterns. In other words, a particular disease may show, let's say, 5 proteins that are expressed only in that disease, or a particular cancer may show specific proteins that are seen only in this particular cancer. This is how the tissue analysis is done. The tissue is placed on a specially coated slide for mass spectrometry. Laser beam is actually, the laser beam is here. A matrix is deposited and trypsin to digest the proteins, and then the laser beam hits the tissue and the mass spectra are obtained. And here is another representation of how the method works. Here is the 5-micron tissue section, which is placed on a specially coated slide for mass spectrometry. Here is the laser beam hitting the tissue, and then the molecules, depending on their size and weight, travel through the chamber and mass spectra are obtained. Each peak here corresponds to a specific molecule with a specific weight and MZ ratio. Here is the chamber, and of course larger molecules travel slower. So the smallest molecules travel the fastest, and they produce the mass spectra. To perform mass spectrometry on tissue, we need 2 consecutive adjacent 5-micron tissue sections. One of them is placed on a special slide for mass spectrometry, and the other one is placed on a regular slide for H&E. Then the pathologist, in this case myself, I choose the areas of interest, and then the 2 images are overlaid using Photoshop. The particular areas of interest that need to be studied are annotated on the unstained tissue section on the coated slide for mass spectrometry. Then trypsin and matrix are applied, and the spots are ready for the mass spectrometer, for the laser beam to obtain the mass spectra from these particular areas. And here are the areas that I try to choose for studying. Initially, the areas of interest were 300 microns in diameter. Currently, they were lowered to 200 micron in diameters, with a tendency in the future to go even to smaller surface areas. This way, we can choose only melanocytic component, or whatever component we need to study, but in our case of melanocytic lesions, only melanocytic component. So I choose areas of densely populated melanocytes next to each other, and I try to avoid epidermis, lymphocytic inflammatory infiltrate, or dermis. And here is the mass spectrometer, and my collaborator, Dr. Erin Seeley, with whom I worked at Vanderbilt and with whom I continue to work. She transferred to a private company, Protea Incorporated, and after calibration of the mass spectrometer, here is what happens. I guess it's not going to work. There was a small video, there was a short video that I was going to show you how the mass spectrometer goes to every single slide, every single dot that was marked for studying with great precision, and obtains the mass spectra. So here are two lesions, a Spitz nevus and Spitzoid melanoma, with marked areas to be studied for their protein content. And here are the mass spectra. In the benign counterpart of Spitzoid lesions, in Spitz nevi, some proteins were more were expressed to a higher degree, and in Spitzoid melanomas, other proteins were expressed to a higher degree. So after our initial study of Spitz nevi and Spitzoid malignant melanomas, we discovered that there are 5 proteins with the MZ ratio, with the following masses that were able to differentially express between Spitz nevus and Spitzoid melanoma. We published our study at the American Journal of Dermatopathology in 2012, and one of our figures was even on the cover. And since then, our article has been the most quoted article for the last 2 years within this journal. Now, the most important question for us is, can mass spectrometry, after being able to find a protein signature which can differentiate between benign Spitz nevus and Spitzoid melanoma, can mass spectrometry help with the atypical Spitzoid neoplasms? Can we rely on mass spectrometry to help in our studying of these difficult lesions? This was the question that I was most interested in. And in 2008, I established a Yale School of Medicine Spitzoid neoplasm repository, in which there are about 3,000 samples of Spitz nevi and Spitzoid melanomas from Yale University and from other institutions and other countries. We had a wonderful international collaboration, and I am extremely grateful to my collaborators and my colleagues from 11 countries throughout the world and 10 institutions within the United States, which sent me atypical Spitzoid neoplasms to study by mass spectrometry. The initial number of cases in our study was 252 cases, of which 102 cases were included in the study The rest of the cases were excluded because there was no follow-up information, unfortunately, or in some blocks the tissue was exhausted and there wasn't enough melanocytic component to perform the study. We divided the cases into 4 clinical groups. Group 1 was only the lesion without lymph node, sentinel lymph node performed, and Group 1 was actually the best group clinically, and Group 4 was the worst clinical group, in which were only patients who had distant metastases and died from melanoma. We then correlated the clinical outcome with the diagnosis that mass spectrometry provided and that histopathology provided to see which one performed better. In clinical group 1, there were 3 subgroups, A, B, and C. In group 1A, patients had no evidence of disease after re-excision and no sentinel lymph node was performed. In 1B, patients had no evidence of disease after re-excision, but sentinel lymph node was performed and it was negative, and in C, sentinel lymph node was positive. In group 2, patients had local regional disease in other nodes, but without distant metastases. Clinical group 3 included patients with distant metastases, and clinical group 4 included patients with distant metastases and death due to the disease. Here is a busy table with the clinical groups 1, 2, 3, and 4, and the subgroups with the number of cases we had in each group. Unfortunately, we had very few cases in the clinical groups 2, 3, and 4. The age of the patients, sex ratio, the average depth of the melanoma, and other variables were recorded. We can look at the last column where we can see the number of cases diagnosed by mass spectrometry as spitzoid melanoma. All cases in group 4 that died of the disease, or group 3 and group 4, in clinical groups 3 and 4, all cases were diagnosed as spitzoid melanoma. In group 2, 2 cases were diagnosed with spitzoid melanoma and 2 cases as benign nevus, and then in the rest of the groups, most cases were diagnosed as benign. This is the best table that represents what's going on with the results from mass spectrometry in atypical spitzoid neoplasms. Please remember that all cases that were included in these studies were ambiguous cases, very difficult spitzoid neoplasms that for which a definitive diagnosis of either benign Spitz nevus or spitzoid melanoma could not be rendered by the original pathologist. So they were all atypical spitzoid neoplasms, but if the original pathologist favored spitzoid melanoma, then here in the histologic diagnosis I put SMM for spitzoid melanoma. So we had 13 cases in which the pathologists favored melanoma, and in all these 13 cases a mass spec diagnosis was spitzoid melanoma. As you can see, 3 of these patients were dead of disease. The rest were alive with disease or with no evidence of disease, but almost each one of them had positive sentinel lymph node biopsy or completion lymphadenectomy or some kind of metastasis or recurrence after a while. The second group was the group in which histologically the pathologists favored that the lesions represented spitzoid malignant melanoma. However, in these 24 cases, mass spec diagnosed all these lesions as Spitz nevi. As you can see, the follow-up in years ranged from 2.5 to 14.5, oh, actually to 24, and all patients were alive and with no evidence of disease. One patient died 6 years after the original diagnosis, bar in a car accident, not related to his diagnosis. In 38 cases, the original pathologist could not favor either benign or malignant. All these lesions were signed out as atypical spitzoid neoplasms. In all these cases, the mass spec diagnosis was Spitz nevus, and all these cases, some with very lengthy follow-up, such as 19 years, the patients were alive and with no evidence of disease, some despite the positivity of sentinel lymph nodes. Then in another set of cases, the pathologists favored Spitz nevi and mass spec diagnosed these cases as Spitz nevi. Again, the patients were alive and with no evidence of disease, with lengthy follow-up. When we performed statistical analysis, it became obvious that there is a very strong association between the diagnosis of spitzoid melanoma by mass spectrometry and aggressive clinical behavior. When we compared group 1 versus group 2, 3, and 4, the p-value was at this range. We also studied different melanoma prognostic factors and compared them, but we found that only 2 of them, older age and greater depth, was strongly associated with clinically aggressive behavior and poorer outcome. We concluded that atypical spitzoid neoplasms diagnosed by mass spectrometry show a strong association with the diagnosis of mass spectrometry, showed a strong association with the clinical outcome than did histopathologic diagnosis. So mass spec performed better than histopathologic diagnosis when the clinical outcome, when the clinical follow-up of these patients was studied. In addition, diagnosis of spitzoid melanoma by mass spec was statistically strongly associated with aggressive clinical behavior. Mass spec can help in the diagnosis of ambiguous cases by histology. Mass spec analysis using a proteomic signature can provide reliable diagnosis as well as clinically useful and statistically significant risk assessment for atypical spitzoid neoplasms. Now let me show you a few examples. Is this a Spitz nevus or spitzoid melanoma? A lesion from the back of a 16-year-old boy. As you can see at low power magnification, the lesion is asymmetric. The cells are large. They are arranged in back-to-back nests that proliferation is so dense that focally forms sheets of melanocytes. The melanocytes are large. They have prominent nucleoli in their nuclei and abundant pale cytoplasm. Focally at the base of the lesion, there was a mitotic figure in addition to other mitotic figures. So in this case, despite the histopathologic asymmetry and many concerning features, which prompted this case to be signed out as atypical spitzoid neoplasm, mass spectrometry provided a diagnosis of benign Spitz nevus, and the patient has been alive and with no evidence of disease for many years. I'd like to show you this example. This is a melanoma that developed in association with a nevus. Unfortunately, The cut is so that the melanoma appears decapitated, but this is the half of the lesion where the melanoma is. So this is the melanoma, and here is at high power. We see that the melanocytes are very large, very pleomorphic, with prominent nucleoli. Now we go to the nevus, and we see that the melanocytes comprising the nevus, arranged in nests, are very small and monomorphous. They have abundant pale cytoplasm. They mature with their descent into the dermis. And here are the two fragments marked with different color for mass spectrometry. And when the mass spectrometry results came back, in the melanoma, 31 of the 35 dots, so every single dot is analyzed, and this is one spectrum. So in other words, 31 of 35 spectra were for the diagnosis of malignant melanoma. In the associated congenital nevus, 15 out of 18 spectra were for a benign nevus. Now let me show you another example. 44-year-old woman presented with a lesion of her left upper arm in March of 2004. It was signed out as a typical Spitzoid neoplasm, favoring atypical Spitz nevus. 6 months later, in September of 2004, she presented with another lesion on the right buttock. The diagnosis, histopathologic this time, was Spitzoid melanoma. The depth was 1.2 millimeters, no ulceration, and there was 1 mitosis per square millimeter. Then another 6 months later, the patient had another lesion from the right upper outer arm, which was again diagnosed as Spitzoid melanoma with 1.2 millimeter depth, no ulceration, and 1 mitosis per square millimeter. Here is one of the lesions, the last one from the right upper arm. You can see that, again, the lesion is asymmetric with more nests on this side. And look at the variation of the melanocytes. They not only vary in size, shape, and staining characteristics, but some of them have a lot of melanin in their cytoplasm, and some do not have melanin. There is really no maturation of the melanocytes with their descent. The base of the lesion is uneven, and the melanocytes are still large at the base of the lesion. In addition, mitotic figures were seen deep in the deep portion of the lesion. Here are some variations in the appearance of the melanocytes. Some have finely granular melanin in their cytoplasm, and some were quite pleomorphic. Here is another mitotic figure. So the one lesion from the buttock that was diagnosed as Spitzoid melanoma was diagnosed as Spitz nevus by mass spectrometry. There was no residual lesion in the re-excision, and out of 7 sentinel lymph node nodes, none was positive for metastasis. The second lesion from the right upper arm that was also diagnosed on histology by Spitzoid melanoma was also diagnosed as Spitz nevus by mass spec. Again, negative sentinel lymph nodes and no residual nevus. So the patient now, 12 years after the original diagnosis of the first nevus, is alive and with no evidence of disease, with 2 melanomas that were 1.2 millimeters in depth. This is a very interesting case. 50-year-old woman presented with a lesion which was 1.5 centimeters in diameter that has developed over the last 1.5 years on the on the right posterior thigh. At low magnification, again, the lesion is asymmetric. The epidermal hyperplasia is also asymmetric. Here are the melanocytic nests close to the epidermis. They vary in size and shape. There are focally fascicular organization of the melanocytes. The melanocytes are large with prominent nucleoli in their nuclei. There were numerous mitotic figures. Here is one, another one, and yet another one in the superficial portion of the lesion as well as in the deep areas of the lesion. Again, pleomorphic, large melanocytes, numerous mitotic figures, prominent nucleoli in these nuclei. Here is the base of the lesion, very uneven. Even here we can see some hyperchromatic nuclei. The cells stay large, they do not mature with their descent. And here at the very base, we have mitotic figures in addition to other mitotic figures throughout the lesion. So, of course, we did not have any choice but call this spitzoid melanoma. The depth was 4.75 millimeters. There was no ulceration, and one mitotic figure per square millimeter. Mass spectrometry characterized this as Spitz nevus. In fact, this case was one of my two cases in the original study comparing Spitz nevi to spitzoid melanomas by mass spectrometry. One of the two cases that did not classify correctly. So because of this case, my specificity and sensitivity was not close to 100, but 90 something. This patient had one of three positive sentinel lymph node, and completion lymphadenectomy was negative. The patient has been alive and well 5 years after the original diagnosis, and as you can see, the depth is quite significant. So at least 1/3 of the patients with that depth would have been dead by now with that depth of a melanoma. So we did not have any question that this was spitzoid melanoma, and I said, well, mass spectrometry is not perfect. So I repeated the studies twice, and twice I got the diagnosis of a Spitz nevus in this case. Once, 35 of 38 spectra were for benign, and the second time, 40 out of 40 spectra were for benign. So I didn't doubt for a second that this was spitzoid melanoma, but not correctly classified by mass spectrometry. And then I got the grant to study, to do genomic, to do exome sequencing of Spitz nevi and spitzoid melanomas. And here, in this, I apologize for that, in this particular table, we see the copy number alterations of 5 of our cases that we did originally for exome sequencing. This particular case of the 50-year-old woman was case 707, and as you can see, there are practically no alterations with the exception of 11p. So this case showed 11p amplification at the exact location where Spitz nevi show 11p amplifications at the exact location of the HRAS gene. So it seems that two molecular methods, one dealing with a copy number alterations and another dealing with proteomics, with study of proteins in the cells, characterized this lesion as benign and not malignant, as a Spitz nevus and not spitzoid melanoma, and again, the patient is alive and well. Here is another interesting case. The question in this particular case was whether the patient has a congenital melanocytic nevus or congenital melanoma. The patient was a healthy Chinese girl which was born at term with a C-section. When the baby was born, there was a 4.7 by 4.2 centimeter plaque on the scalp. The plaque was well demarcated. In only 7 weeks, which is less than 2 months, the plaque grew to 10 by 9 centimeters. It was ulcerated, necrotic, hemorrhagic, and this is how it appeared when the mother brought the baby to the dermatologists and to the plastic surgeons. The plastic surgeons decided to excise the entire lesion, and they did. They covered the defect with the graft. Here is a low power view of this lesion. We can see that this, on the top here, we still have epidermis, so it's not an ulcerated portion of the lesion, and we have nests of pigmented melanocytes in the epidermis and in the upper portion of the dermis, and then there are nests of melanocytes throughout the entire dermis and extending into the subcutaneous fat. Here are the very pigmented melanocytes organized in nests within the epidermis. And here is a portion of the lesion that was necrotic in its upper half. So here is still viable part of the lesion, and then complete necrosis of the surface epidermis and of the upper reticulodermis. The melanocytes were organized in nests that were kind of swirly. They were relatively monomorphous. They looked alike. However, there were foci of necrosis and mass in the center of this particular aggregate, and also numerous mitotic figures. This is a Ki67 proliferative marker, which labels numerous nuclei within the lesion. So about 15 to 25% of the nuclei in this lesion were positive. They were proliferating. And when we did HMV45 staining, as you can see, the lesion showed patchy but diffuse positivity with the marker. As we all know, HMV45 should be negative within benign melanocytic nevi, or occasionally it may only stain the superficial portion of the nevi, and HMV45 is positive within melanomas. So there were a lot of conflicting histopathologic criteria, some pointing into the direction of a nevus congenital, and others pointing into the direction of melanoma. It is to no surprise that the lesion was diagnosed as melanoma at 2 Chinese hospitals. The plastic surgeon who was visiting from China for 6 months studying with our plastic surgeon was sent to me by our plastic surgeon, and he brought me the slides, and subsequently he got the block because we needed that to perform mass spectrometry, and he said, I don't believe this is melanoma because the patient is doing well. Then we sent the case to mass spectrometry, and 20 out of the 20 spectra classified the lesion as nevus. Here is the patient, 3.5 years after her birth, beautiful girl, who went back to the plastic surgeons to do some cosmetic operation and transplant some hair and make again her scalp look beautiful and normal. Another interesting case in which mass spec really helped, congenital nevi or metastasis. A 32-year-old pregnant woman noticed a lesion on her right upper arm. It was red. She thought maybe it was hemangioma. She showed it to her OBGYN clinician. The OBGYN said, oh, maybe it's pyogenic granuloma, don't worry about it. But the lesion continued to grow, and eventually she went to her dermatologist, who performed a wonderful excisional biopsy, including the entire lesion. And here is the low power view. As you can see, the lesion is asymmetric. This can be particularly assessed in the lower half, where there are some areas of large nests and some denser areas of cells with higher nuclear to cytoplasmic ratio. Look at this absolutely atypical melanocytes, which was so horrifying that I'm not sure I've ever seen any more bad-looking melanocytes. In addition to these very large and pleomorphic atypical melanocytes, there was a nodule within the melanoma that contained melanocytes with very high nuclear to cytoplasmic ratio, kind of on top of each other, practically nuclei with prominent nucleoli, mitotic figures, of course. After the excisional biopsy of the mother and the diagnosis of malignant melanoma, the clinicians decided to wait another 4 weeks until the baby reached term and then excise, do a re-excision and sentinel lymph node biopsy. When the baby was born, and this is day 0, immediately after the baby was born, there were a few atypical melanocytic lesions, a few on the back, and this is also on the back, but more kind of laterally, and one on the flank. So the dermatologist's team was immediately called, and they biopsied 2 of these lesions. The question was, were these atypical melanocytic lesions in the baby congenital nevi, or were they metastases from the mother's melanoma? Because if they were metastases, the mother's clinical stage would go to 4. Here are some comparative histopathologic pictures. One of the nodule of the melanoma with the melanocytes with high nuclear to cytoplasmic ratio. And here, as you can see, the cells of the lesion in the child had very similar appearance with nucleoli in the nuclei and scant cytoplasm. Ki67 was expressed in a high majority of the nuclei of the lesion, so high proliferative activity within the lesion. And here is mass spectrometry. Here is the mother's melanoma, and here are 2 lesions from the baby, all marked for mass spectrometric examination. Now, you can compare the mass spectra of the mother on top in blue and the baby in red. As you can see, the mother's lesion have different spikes of proteins than those of the baby. The mother's lesion classified as malignant melanoma, and the 2 lesions from the baby classified as nevi. So in this case, mass spectrometry was very helpful. In addition, the baby was a boy, so we performed a DNA study, and with the 2 lesions having Y chromosome, this was another confirmation that the lesions belonged to the baby. They were congenital nevi and not metastases from the mother's melanoma. So in conclusion, mass spectrometry can work on formalin fixed paraffin-embedded tissue sections. What is needed is only 2 5-micron thick sections, consecutive, placed on special slides. Mass spectrometry is a reliable method that can differentiate benign nevi from malignant melanoma based on their proteomic differences, based on their differences of protein content. Mass spectrometry can also help in the diagnosis of ambiguous cases by histology, and it is objective, fast, and relatively inexpensive. This is something that is beyond H&E. It can look at the cells on a molecular level and help with the diagnosis. Thank you very much for your attention, and I would welcome any questions or comments.
Thank you so much, Rossitza. It was absolutely mind-blowing. It was fascinating talk. We are ready for the questions.